just to let everybody know, we will be recording the lecture today. Got one or two people that are out for legitimate reasons, and so I'm going to try to record it, and I'll post it and send the link out to everyone. So let's continue on with our study. Okay, what's the deal here? Hold on. Batteries have gone low. Okay. Maybe we'll continue on. There we go. Let's continue on with just a real brief review of the PVCs, and then we're going to get into the different varieties of PVCs that you might see. One of the things to keep in mind is typically when you look at a PAC, they're pretty much shaped and they have the same format, the same criteria from one PAC to the next. PJCs are a little bit different in the fact that you may have an inverted P wave or no P wave whatsoever, but they're early with a compensatory pause. Interesting thing about PVCs that even though they occur and they're generated from way down deep in the ventricles, you can have different shapes, different morphologies, and they can occur in groups of 2, 3, or 4 or more. And so what I want you to begin doing now is to begin, after today, identifying these different groupings as well as whether they're multifocal or unifocal PVCs when you see them on an EKG. Again, just going back to what our review was very briefly, your rate, remember, PVCs are isolated beats or an isolated beat. You may only have one in a 6-second period, or you could have multiple ones. So it all depends upon the underlying rhythm. And again, Martina brought up some really good points as far as the Huff book. I like the Huff book because there's so many doggone EKGs in there for you to go through and to identify. But I disagree with some of her interpretations of some of them. And like I said earlier, she regularly will call sinus block sinus arrest and then call sinus arrest sinus block. But they're two different types of rhythms. I think it may not be the exact same rhythm, but I was looking at one in there that she called normal sinus rhythm, but you are exactly right. When you go in and you look at the rhythm, when you count the number of QRSs between the hash marks, that's not a normal sinus rhythm. It's less than 60. So I will tell you the vast majority of your EKGs that you will see on your online quizzes as well as in your class quizzes come from that book. So you want to get familiar with it. But again, just kind of keep those things in mind that we're looking at. So again, anytime you have a premature beat, whether it's PAC, PJC, or PVC, you count the premature beat as part of the rhythm, okay, part of the rhythm. Within PVCs, it's going to be an irregular rhythm. Okay. Now, with PVCs, it could cause your rhythm to be irregularly irregular, okay, if they're just happening kind of all over the place. Or PVCs sometimes begin to discharge and fire, Matthew, in a pattern. And so as a result of that, we still can't call it a regular rhythm, but what we can say is that it is a regularly irregular rhythm. There's a recurring pattern. And again, like I've shared with you, Landon, one of the things that you may need to do, run a longer piece of paper or watch it closer on your monitor as you're going through. Identifying rhythms on a moving monitor is just a little more difficult than looking at a piece of paper. That's why I save that towards the end of the class, and we really get into that in the advanced sequence of being able to identify rhythms just from the screen, because that's typically going to be how you're going to do most of them. You have no P waves with a PVC. Why? Because it's coming from the ventricles, okay? And so it does not generate a P wave, but it does depolarize the atria, okay? And the reason we don't have a P wave, Jack, is because it gets swallowed up in that wide, bizarre-looking QRS. So there is a P wave there, we just can't see it. But the thing is, we can't work off the assumption, Sydney, that simply because we see it that it's, or we don't see it but we know that it's there. We just simply say there's no P wave. And if there's no P wave, you don't have a PR interval. So you don't have to worry about that. Here's one of the things that's going to be really, really identifying about these rhythms. They're almost always going to be really wide and bizarre looking, okay? Greater than 0.12 seconds. Now, one of the things I want to kind of plant a seed in your brain right now is that particularly, and we're going to talk about ventricular tachycardia today. Ventricular tachycardia is usually one of the easiest rhythms to identify. The only other rhythm that I think that is easier to identify is a systole, okay? Nice flat line. However, remember I said it was almost always the easiest rhythm to identify. Sometimes you're going to have a patient and you're going to look at the patient and the patient's going to be symptomatic and you're going to go, not sure if that's VTAC, not sure if that is SVT. Usually when we see these types of rhythms, they're really, really fast. The faster the rhythm, the more narrow the QRS is going to be, okay? So you won't be tested on this yet until next week we're going to go over pharmacology. So the thing to remember is that we have a drug called adenosine, okay? You'll learn about adenosine. It's really a quite amazing drug. It works well. It's very uncomfortable for your patient, but the good part about it is the side effects only last about 30 seconds, okay? Basically what we're doing when we give adenosine is we're stopping the heart. So we can have anywhere from a 6 to 12 minute period in which the heart is not beating, okay? It's not pleasant for your patient. It makes them hurt. It makes them sweat. They may feel like they...
Minutes, right?
I'm sorry, seconds.
Okay,
I'm sorry. Yeah, please correct me when I say that's a goober statement, okay? Yeah, yeah. That's going to cost you your license if you give that. So 6 to 12 seconds, not minutes. And so your patient has just this really uncomfortable feeling. Why? Because you stopped their heart. And I will tell you, the saying within EMS is the first 2 times that you give adenosine is first you give the patient chest pain, and then when you look at that long strip of the systole, you begin to have a chest pain, okay? But the thing is, adenosine only works on SVT. It does not work on VTAC. So you can utilize adenosine as a diagnostic medicine in addition to a treatment. So when you look, Matthew, at that rhythm, you go, I don't know. I don't know. It's borderline as to whether it's too wide, but it's not, doesn't look wide enough to obviously be it. So what we do is we get an IV started, we give a dose of adenosine. If nothing happens, then we go, aha, it's got to be VTAC. And then we go down another treatment pathway. And we'll talk more about that treatment later. But again, with PVCs, they're going to look weird. They're going to look wide, okay? Now, when we are looking at this, again, keep in mind 2 things about premature ventricular contractions. Number 1, it's early, okay? So when you see this, Jack, it's going to come up early. Now, premature beats are often difficult to identify, Josh, when the rhythm is fast, okay? So you may have to get out your piece of paper and measure your R-to-R intervals and look at that really, really closely, okay? The other thing that we see with almost all premature beats is that we have this long area here, this pause. And what is that pause called? Compensatory pause. And what's the purpose of the compensatory pause?
For the heart to try to regain control.
Yeah, so it's trying to get back to where there's a primary pacemaker. And we see that in here, okay? So we've got, what appears to be a normal P wave, normal QRS, and then we get this early ectopic beat coming from the ventricles. How do we know? Because it's really, really wide. And then we have this pause that allows everything to reset. And look at that. The same cardiac cell that caused this one is most likely the one that is causing that one there as well. Okay? So that's going to be really, really important when you're looking at PVCs. All right? Now, when we are looking at PVCs, they can come in what are known as unifocal PVCs or multifocal PVCs. So let's take a look at this one right here for a little bit. Let's just go across this whole strip here. What is the rate?
The first one? 80.
8 of the top one. Yep. Okay. Rhythm.
Regularly irregular.
Good. It is regularly irregular. So this is one of those times when we can see in the 6-second strip that we've got a pattern to our irregularity. It's still irregular, but there's a pattern. It's a repeating pattern. Okay? P waves.
Some of them are there.
Good answer. Some of them are there. Okay? Get your laser pointers out. Richard, you got your laser pointer? Show me where the P waves are.
So you got one there, one there, one there, and one there.
Okay, good. So the beat that follows it afterwards does not have a P wave. Okay? What's the PR interval?
For those that have a P wave, it's
There are P waves.
Yeah.
Say it again.
Where you can see the PR interval, it is good.
Yeah.
Okay, very good. So where we have a PR interval, it is within normal range. Okay? What do we notice about your QRS?
It's wide.
Eh,
It's not wide. It's
eh.
some are wide, some are normal.
There you go. Okay, I can make all kinds of noises. All right. So our first QRS here, this is within a normal range. Okay, but if we measure this one, and we would measure starting from right here to it would end right there, we would find that that is wide. Does that look different than most other QRS complexes that we've looked at? Yeah, it does. So it's wide and bizarre looking. So ladies and gentlemen, how would you identify this rhythm?
Normal sinus rhythm with premature ventricular contractions.
Okay, that's good. At this point, that's all that you know to call it, okay? We're going to drill down and we're going to call it something else, okay? So it is normal sinus rhythm. And Sam, how many PVCs do you see in this particular rhythm?
4.
4, okay? 1, 2, 3, 4. You're exactly right. Now, one of the things to keep in mind is one of the reasons that patients begin to have PVCs is that because the heart is irritable, in particular the ventricle is irritable for some reason. Now, what do you think would be the most common cause of ventricular irritability? Everybody in here knows this answer. You're going to kick yourself if you don't say it.
caffeine.
Say it again.
Is it caffeine?
Not the most common, but caffeine can definitely cause it. Okay. What else?
Are you on ischemia of some sort?
Ischemia or hypoxia. Yeah, very good. So the most common cause of ventricular irritability is going to be hypoxia, which leads to ischemic tissue. All right. Now, when we see PVCs, keep in mind we go, big deal, PVCs. Okay. Or we go, oh my goodness, big deal, PVCs, okay? So, again, don't treat your monitor, treat your patient, okay? So when you see something like this, immediately go back and reassess your patient, okay? Is my patient awake, alert? Is she complaining of chest pain, having any difficulty breathing? What's her mental status? What are her vital signs? And then use that and the findings from the patient to come up with your diagnosis as to whether or not you need to be worried about these, or they're just maybe even normal for the patient. When we have these types of PVCs, okay, these are called unifocal, U-N-I-F-O-C-A-L, unifocal PVCs. And what does unifocal mean? Richard?
It's coming from a single pacing site in the ventricle.
Okay? Tell me a little more. You're about 85% of the way there.
So unifocal is uni meaning one and focal meaning focus point.
Mhm.
So where all of those are the same exact shape and structure PVC, you can tell they're coming from the same point.
Perfect. Yep, you're exactly right. Remember that cells in the heart, when they depolarize, much like each one of us in here, we have individual fingerprints, okay? And you can be